Today we're going to be discussing compounding, reconstitution, and repackaging, which is honestly one of the more unique areas of pharmacy, so it should be a pretty fun discussion. After this lecture, you should be able to define compounding, reconstitution, sterile compounding, non-sterile compounding, and unit dose, recognize the role of compounding, reconstitution, and repackaging in pharmacy, identify basic techniques and equipment used during compounding, differentiate between types of non-sterile and sterile compounding, assign a beyond use date to reconstituted or compounded medications, and comprehend the legal requirements associated with compounding and repackaging medications. So starting with compounding and reconstitution, compounding is the combining, mixing, or altering ingredients to create a medication tailored to the needs of an individual patient. So this could be either sterile or non-sterile, with sterile meaning that it's free of living microorganisms, so free of bacteria and viruses. On the contrary, reconstitution is adding a diluent to a dry ingredient to make it a liquid. So the product's already commercially available, it just needs to be mixed with water or some other liquid in order to be used. So here are some of the legal requirements of compounding. The compound must be patient or office specific. It cannot cross into manufacturing. So manufacturing is considered the preparation and promotion of commercially available products from bulk compounds for resale by pharmacies, practitioners, or other persons. So it has to be made for a certain person. It has to be on a prescription. We must keep on hand the formulation records, compounding records, standard operating procedures, and ingredient records, which we're going to talk about more. And these requirements are only for compounded medications. Reconstituted medications do not require these documents. First, we'll discuss the formulation record. So sometimes this is called the master formulation record. The components that are needed in a formulation record include the name, strength, and dosage form of the medication, the physical description, so what the color and the texture looks like, description of all of the ingredients and quantities, the complete instructions for preparation, including the equipment, supplies, and sterilization method, the assigned beyond use dates, or BUD, so you may extend the BUD if referencing an established compatibility and stability, storage requirements for the compound, the quality control procedure. So quality control is a system to maintain standards by testing a sample against the control specifications. So this may mean if you're making a cream, testing a little bit of the cream against a control cream to make sure that it was up to the right quality to dispense. It can include pH manipulation, sterilization, visual inspection, and weight assessment just to ensure that the product is actually of high quality. It also requires the labeling and packaging information, the literature references for the compound you made, any relevant calculations you did, and then the developer/verifier information and date. So now we're going to look at an example of a formulation record. So you can see here there's a place for the name, strength, and dosage form, and this is just an example. All formulation records can look different than this, but just a general idea of where those requirements are placed. Then we move on to the developer and verifier information. And then we see a place for our beyond use date, the packaging information, the equipment that we use to make the compound is listed here, and then the ingredients and quantity. And then you see where there's an area for the compounding directions and procedures for you to put all of the procedures that you use to make the compound. And then here you have your quality control procedures, the labeling information, the compatibility and stability information, as well as any references you use to make the compound. Next, we'll discuss the compounding record. This should be completed at the time of the compounding. So compounding records contain a lot of the same information as your master formulation records. The compounding records are specific to a patient's prescription though. So the master formulation record is basically your recipe for making the compound, whereas your compounding record is where you actually made it. It must contain the name, strength, and dosage form of the compound, the compounding record identifier, all ingredients, quantities, manufacturer, lot numbers and expiration dates for the things you used for the compound, detailed steps used to produce the formulation, results of the quality control procedures, the packaging information, any relevant calculations, so these should be done in master formulation but should also be documented if needed, the labeling information, the final check information, and this should include the name of the person who compounded it as well as the name of the pharmacist who performed the final check. And again, we have another example of a compounding record. Not all compounding records are going to look like this. This is just an example of how some of the information is organized. And once again, a section for your compounding directions and procedures. Now moving on to our standard operating procedures. These may also be called SOPs. So these are documents that detail written instruction describing what steps to follow under specified conditions. They help to ensure quality performance and quality products and preparations. Consistent policies, operational standards, use of equipment, space, chemicals, and commercial products, and documentation of SOPs serves as a permanent record of how the pharmacy is operating. So this is your basically rule book for how to handle things day to day. This is going to include information about if there's a spill within the pharmacy, if somebody is exposed to a chemical within the pharmacy. It's going to tell you how you should be cleaning your instruments, how you should be disposing of things. Your standard operating procedures should be your reference for most things while compounding. Then we have our ingredients record. That's a record of all of the ingredients used in the pharmacy for compounding. It's going to include the certificates of analysis as well as the material safety data sheets. So a certificate of analysis is a document that's issued by the quality assurance stating that the product meets its specification. So this is basically receiving a certificate that says that if you ordered a powder, that the powder is 98.5% that powder. It's where the company went behind and weighed the powder, did whatever they needed to do to verify for you that you actually received what you ordered. The Material Safety Data Sheet, or MSDS on the other hand, is a document that contains information on potential hazards and how to work safely with a chemical. So this sheet is going to tell you what to do if your eyes are exposed, if your skin is exposed, how to handle it, whether something is flammable, all of those details. And you should keep both of these documents for every ingredient that you're compounding with in a binder or an electronic file together for your retention. So here we have an example of a certificate of analysis. You can see the test that they did, the specification that it should have been, and then what result it was. So you'll be able to see how it compared to what the quality standards was for the company. And then here we have a material safety data sheet. This is the top part where it tells you what the product name is, where it came from, as well as any of its hazard identifications. Then we move into the physical and chemical properties. So this is where it's going to tell you whether or not it's flammable, things like that. And then the stability and reactivity, it tells you things to avoid, all of those good things to know before you handle chemicals. Now we're going to switch and talk a little bit about the compounding workflow. So this is going to vary by pharmacy. Every pharmacy's compounding workflow is a little bit different. It even varies by state. So the basic workflow typically includes preparation, compounding, final check, a sign-off, and cleaning. So starting with preparation, first you must determine the safety and suitability of the prescription for the patient. So do we think it's safe to make this compound for our patient? Then you'll perform your calculations in order to determine all of the ingredients you need and how much. You'll select and clean your equipment for the compounding. Put on the proper PPE or personal protective equipment and wash your hands before you start. You'll clean the compounding area typically with alcohol. That's a pretty standard substance to use to clean your compounding area both before and after compounding. And then you'll assemble all of your materials and ingredients for compounding and packaging. So what this typically looks like is somebody will bring a prescription in. The prescription will get entered into the system and we'll make a decision on whether or not the compound is appropriate and safe. Then from there, you'll go ahead and do the calculations to ensure that you have the correct amount of ingredients, the correct quantity of ingredients, and the correct concentration for the prescription. Then you'll find all of the equipment that you'll need to use, and we'll talk a little bit more about equipment types throughout this entire series. You'll put on your PPE. This may include goggles, a face mask, gloves, and you'll wash your hands, obviously, before you put your gloves on. Cleaning the compounding area, we talked about using alcohol to wipe everything down, and then assemble your materials. If you're using a hood, I like to put all of my ingredients and all of my equipment inside the hood, nice and organized so that I'm ready to start the compound. Then you have the actual compounding. This is the preparation of the actual compound. This involves techniques that we're going to discuss later in the chapter. So this is the step where you actually make the medication. Then you traditionally move into the final check. So this is different than the traditional verification that we'll talk about more throughout this course. Verification of this product should only be done by the pharmacist, and you're going to check the weight variation, the mixing, the clarity, the odor, the color, consistency, and even the pH sometimes. You enter all of this information in the compounding log and then label the prescription. So this is when the pharmacist is going behind, and if the prescription was written for 30 grams of a cream, the pharmacist is ensuring that you're near 30 grams within reason. So maybe you're at 29 grams or 31 grams. That's okay. Your standard operating procedures will have a cutoff for what your minimum or maximum will be, but the pharmacist is just checking that it looks okay, it seems right, the pH is good, the weight is accurate, all of those things pertaining to the compound specifically. So less to do with the prescription and more to do with the actual compound and how the compound was made. That leads me into the sign-off, which is different from the final check, like I said. The final check is confirming the compound was made correctly. So sign-off compares the prescription to the compound. So this also should be completed by the pharmacist. And you want to sign and date the prescription to confirm that all the procedures were carried out to ensure the uniformity, identity, strength, quantity, and purity. So this step is less about the actual compound itself, but making sure that we're dispensing the right thing to the patient, making sure that we use the right drug, we use the right strength, all of those things so that it's going to work for the patient. Now we have the cleaning step. This helps to prevent cross-contamination. Cross-contamination is the transferring of unwanted material from one object to another. It's important to know that cross-contamination can be with bacteria and virus, but also with other drugs. So if you make something with a sulfa drug in your hood and you don't clean your hood afterwards and you make another compound, that sulfa drug could then get into your new compound, and if the patient has a sulfa allergy, they can have an allergic reaction to it. So cross-contamination is a very serious thing. It's something to take very seriously. So you're going to want to clean the compounding area using alcohol for surfaces and bleach for any cytotoxic materials, then store all of your supplies. You're going to want to change any of soiled materials, so your jacket or your scrubs, and wash your hands. And then follow any disposal instructions per your SOPs, like I said. So your biohazard container is typically going to be meant to dispose of bodily fluids, any chemotherapy medications, or other biomedical waste. Sometimes you'll see separate containers for chemotherapy medications. The red containers will typically be for your normal drugs, and the black containers will be for your chemotherapy medications. You'll also see sharps containers, which are a special type of biohazard containers that are hard, and they're specifically made for needles and broken glass. You'll use these a lot, especially with sterile compounding, when you're manipulating a lot of glass and needles. When you're manipulating a lot of glass and needles. Some of the equipment you may use while compounding includes mortars and pestles, graduated cylinders, beakers, ointment slabs, laminar flow hoods, syringes, needles, and more. With that being said, some of the techniques you're going to use are going to be reading liquid volume, and that's going to be applicable in both compounding and reconstituting. We're going to discuss more specific techniques as they're appropriate within the section. So starting with that common equipment, First, we have beakers. These are the least accurate and they're used to measure large quantities, versus graduated cylinders, which are going to be the most accurate for measuring liquids. You're always going to want to go with a graduated cylinder over a beaker when you have to measure liquids out. You have a mortar and pestle that's seen at the top, and a laminar flow hood that's seen in the bottom right. We're going to talk a little bit more about personal protective equipment. It's used to protect you while compounding. The degree of PPE needed is based on whether the prescription is hazardous and if it's to be compounded by sterile or non-sterile means. So this may include gloves, suits, shoe covers, hair covers, face shields, masks, jackets, gowns, goggles, and more, just depending on how safe you need to be when making this preparation. So you see a good example in this picture of someone wearing a gown, gloves, hairnet, goggles, a face mask, all of these things to protect her while she's making the medication, but also to protect this sterile medication from getting contaminated. So moving on to reading liquid volumes. Accuracy is largely determined by the device that's used to measure a liquid. So we talked about graduated cylinders already. You should always use the smallest device that can adequately hold the amount of liquid you're measuring. So for example, if you were asked to measure 225 mLs, you should use a device that can hold 240 mLs. You want to go as close to the amount you need to measure as possible. Always opt for a graduated cylinder over a graduated conical or beaker, like I said. Now an example of reading liquid volumes. The surface tension of a liquid causes it to loosely bond with any surface it comes in contact with. So that loose bond creates a curve at the top of the liquid where we use to measure, called the meniscus. So liquid volumes should be read at eye level and should be measured from the bottom of the curve. So you can see here an example in the top left of somebody at eye level reading that curve, and then in the top right, we have an actual meniscus that you can see is right at 6.6 mLs. When we zoom in, you can see that it's right there at the bottom of the curve that we measure from. Moving on to medication reconstitution. Medications that must have a liquid or base added to them before dispensing are considered those that need to be reconstituted. Common medications that require reconstitution include antibiotics, PPIs, and injections. Manufacturer's label will have instructions for the reconstitution, the storage, as well as the dating of the medication. And they should always have appropriate auxiliary labels added to them. So this includes shake well, store in the refrigerator, and then how many days it expires in. With this being said, since it does expire in X amount of days, you're going to want to wait to reconstitute these medications until the patient arrives to pick it up or it's time for use. And these do not require a log like compounded medications. So here we have an example of a reconstituted medication. It's an amoxicillin oral suspension, and we can see here the directions that are written to the pharmacist up at the top. So the proper procedure for the reconstitution would be to measure the appropriate amount of distilled water or other diluent that you need for reconstitution. That's going to be on the label. So on this label it says 60 mLs of water. You want to add approximately 1/3 of the water to the bottle. So you're going to add about 20 mLs of that 60 to the bottle. Invert the bottle and shake profusely, tapping powder from corners to loosen. So with that 20 mLs in, you're going to shake it and try to tap all of the powder out of the corners just to get it nice and loose. Then you're going to turn the bottle right side up and add the remainder of the water and shake profusely. So after you've loosened all the powder with that 20 mLs inside, you go ahead and add the other 40 milliliters, shake it really profusely until it's nice and uniform, and then you're done. Now to discuss beyond use dating. The manufacturer establishes the stability data, including the beyond use date for reconstituted medications. It's typically going to be within 10 to 14 days, and they may or may not require refrigeration. That's also going to be in the instructions. Refer to the antibiotic suspension storage for more information on storage and beyond use date of commonly reconstituted medications. This should be in the folder with the chapter. We're now going to start to look at some of the specifics of compounding, starting with sterile compounding. It's typically used to make parenteral medications, with parenteral meaning medications that are inserted into the body and means other than the mouth, so typically by injection. They must be compounded in a sterile environment because they are going straight into the bloodstream, and they could be classified as either high, medium, or low risk. Some common terms in parenteral medications: you have IV antibiotics, which are used when a patient has a chronic, resistant, or blood infection. IV pain medications, often given as a PCA or patient-controlled analgesic, is whereby a patient can control the frequency of administration. So basically a morphine button where the patient can hit the button to get a dose of medication. You have IV push, which is when all of the medication is in a syringe and it's given at one time. You have a continuous infusion, which is where a medication is continuously infused into a patient over a specified period of time. And then IV piggyback, which is medications that are delivered over top of the main line of fluids via IV. We also have TPNs, or total parenteral nutrition. These are fluids comprised of proteins, fats, carbs, electrolytes, multivitamins, nutrients, etc. They're used when a patient's unable to receive traditional nutrition, so if they can't eat by mouth at the time. We have normal saline, or NS. This is 0.9% sodium chloride, as you can see here in the bag to the right. Sometimes you'll have half NS or half normal saline. That would be 0.45% sodium chloride. You can also have quarter normal saline, which is 0.225% sodium chloride. D5W is another very common fluid. That's 5% dextrose and water. D10W likewise is 10% dextrose and water. And then finally, ISO is the International Organizations for Standardization. They provide standards for the air cleanliness and sterile compounding facilities. So now, the sterile environment. Sterile means limited number of 0.5 micron and larger particles in the room air per every cubic meter of room air. So air is considered to be sterile and without microorganisms if there are very few numbers of particles that are greater than 0.5 microns large in the air per every cubic meter of room air. There are 5 different classes of sterility, with the most sterile being class 3. So class 3 has 35.2 particles per cubic meter. Class 4 has 352 particles per cubic meter. And then likewise, you can see how they increase from there, with class 5 having 35,200, class 7 having 352,000, and class 8 having 3,520,000. So class 3 has a very small number of particles per cubic meter, whereas class 8 is where you're moving up to where you may have more particles in the air that can contaminate. So because keeping compounds sterile is so important, there are specific requirements of the pharmacy facility to ensure sterility. First, you have primary engineering controls, or PECs. This is a device or room that provides an ISO class 5 environment. So it must contain a special high-efficiency particle air, or HEPA filter, and it may be a laminar airflow hood, biological safety cabinet, etc. So as long as it has that number of particles that we discussed in the last slide that qualifies as a class 5, it can either be like a full area or an actual hood. Then we have our secondary engineering controls. This includes a buffer and anti-area. So the buffer area is an area in which the primary engineering control is, and it should be at least an ISO class 7. The anti-area, on the other hand, is the area in which you do your hand washing, your garbing, and your product decontamination, and that should be at least ISO class 8. So as you can see, we're doing the actual compounding in ISO class 5. Where we're doing the compounding is typically held in an ISO class 7 area, and then where we're getting ready for the compounding, where we're garbing and doing our hand washing, is in the dirtiest area, or the ISO class 8. Unless compounding hazardous drugs, all rooms and workspaces should have positive pressure. So that means that air blows out of the room when the door is open. This is in an effort to push anything that's not supposed to be in the room out. If you're compounding hazardous drugs, the room should be negative pressure, and the anteroom should be an ISO class 7 to prevent particles. So you're going to want your anteroom to be a little bit cleaner than the typical anteroom, and negative pressure just means that air draws in when the door is open. This is because you're typically dealing with something that's hazardous to other humans, so you don't want to push it out of the door when the door opens. You want to suck it in like a vacuum so other people aren't exposed. So here we have an example of a non-hazardous clean room. We can see the hood or the primary engineering control is ISO 5 at the bottom. That's contained within a buffer area, which is ISO class 7 with the air pushing outwards. Then we have an ante area, which is an ISO class 8 area, and again, the air is pushing outwards. So if you open the door to the ante area, you're going to have air flow outwards, and then if you open the door to the buffer area, you're going to have air flow into the ante area. So everything should be flowing outwards. Now looking at a hazardous example, you have your engineering control is the ISO 5, the same as it was before, but now your buffer area is the ISO class 7, and it's sucking all of the air in to keep any of those hazardous materials from entering the ante area and ultimately the rest of the pharmacy. Your ante area is the same, where it's pushing air outwards to prevent things from getting into the buffer area. However, now it's an ISO class 7, just to prevent anything from getting sucked into the buffer area that shouldn't be there. Here are some examples of airflow within hoods. It's really important to understand the airflow of hoods. So you have a horizontal airflow hood as well as a vertical airflow hood. Horizontal airflow hoods are typically used in non-hazardous compounding because, again, it's pushing the air out towards you. So anything that is in the hood that you don't want in the hood, it'll just simply push it out of the hood. Well, with hazardous medications, we don't want that pushing towards us. We don't want to breathe in hazardous medications. So we'll use a vertical hood. In this situation, the air pushes from the top down to keep things sterilized. This keeps the air from getting pushed towards you to where you'll get contaminated. Instead, it goes down into the hood again and gets recircled around and just keeps flowing vertically down. So aseptic technique is something that's going to be used when you're doing sterile compounding. It's used to prevent contamination with microorganisms. It includes changing PPE, cleaning the workspace between compounds, remaining 6 inches from the edge of the hood, and good needle handling techniques. You can review course videos to observe proper aseptic techniques. These are posted within the chapter for you. So looking at low, medium, and high risk compounds, they're classified based on the likelihood that it could become contaminated and the number of aseptic manipulations needed to compound. So a low risk compound involves not more than 3 commercially manufactured sterile products and not more than 2 entries into a sterile container or package. So you're going to be using less than 3 products and no more than 2 times are you going to stick a needle into a package. Medium risk compounds, on the other hand, are compounds that involve multiple individual doses or multiple small doses of sterile products pulled together to make one product. So the process includes complex manipulations using 4 or more sterile ingredients. Finally, we have high risk, which is a compound that involves non-sterile ingredients and or it is compound using any non-sterile equipment. So this is when you're incorporating non-sterile things, meaning the compound's going to ultimately have to be sterilized. First, we have our low-risk example. This would be withdrawing liquid from a sterile commercially made vial to inject into an IV bag. So you're sticking the vial once to draw the liquid up and then sticking the bag once to inject it into the bag. So a total of only 2 manipulations and 2 products. Then we have a medium risk example, which could be injecting multiple nutrients into a bag for a TPN or that total parenteral nutrition like we talked about earlier. So you may have a bag and you inject like 5, 6, 7, 8 things into it so that the patient has all of their nutrition in one bag. Then finally we have our high risk example. This would be dissolving non-sterile powder into a fluid to be injected. Since it is non-sterile and it has to be injected into the bloodstream, you're going to have to do some form of sterilization for this. This may mean pushing it through a filter or putting it in an oven, but it is important to recognize that with high-risk medications, you do have to do some form of decontamination. For the beyond use stating for sterile compounds, it's based on the risk of the compound. So if you're doing low risk in a segregated area, so outside of a hood, this is commonly done in hospitals on the actual floor where the patient is. It's good for 12 hours at room temperature. If you're doing a low-risk compound in traditional compounding standards, it's 48 hours at room temperature, 14 days in the refrigerator, and 45 days in the freezer. If you're doing medium-risk compounding, it's going to be 30 hours at a room temperature, 9 days in the refrigerator, and 45 days in the freezer. And again, this is in standard compounding conditions. And then high-risk compounds under standard compounding conditions and after being sterilized are good for 24 hours at room temperature, 3 days in the refrigerator, and 45 days in the freezer. Now we'll dive into non-sterile compounding. This is also known as extemporaneous compounding. This is the process of creating a prescribed substance that's not commercially available, so you can't just buy it from a wholesaler. They do not have to be free of sterile, or it doesn't have to be sterile or free from living organisms. So these may have some bacteria and viruses in them, and that's okay. They're oral, topical, vaginal, rectal, otic, or ear, and nasal dosage forms. So none of these areas in your body are sterile. We have bacteria living on them already. That's why it's okay that they're not sterile. And they're categorized into simple, moderate, and complex compounding. Starting with simple non-sterile compounding, there are 3 types of simple non-sterile compounding. One is if there is a readily available USP compounding monograph. So currently there are just over 170 USP monographs available. The second is if the product appears in a peer-reviewed journal article that contains specific quantities for all components, compounding procedure and equipment, and stability data with an appropriate beyond use date. So this is where somebody has studied this compound, published their recipe for it in a peer-reviewed journal with all of the information needed. Then finally, the last example of simple non-sterile compounding is the reconstitution of commercial products that may require the addition of one or more ingredients as directed by the manufacturer. So this type of product, as mentioned before, does not require a compounding record, whereas the top 2 do. Now, moderate non-sterile compounding, there are 2 types of these. First is the compound requires special calculations or procedures to determine the quantity of the components used in the compound or individual dosage units. So you see this with suppositories, troches, and capsule molds. Before you can make your suppositories, you need to calibrate your molds and know just how much fluid they hold so that you can understand how much fluid you need to add to the compound in addition to your active ingredient. So this requires a pretty special calculation, which is why it puts it in the moderate category. The next type of moderate non-sterile compounding is if the compound does not have specific stability data available. So if you're mixing 2 different products, the stability data is not known for. And finally, we have complex non-sterile compounding. This compounding requires special training and environment, facilities, equipment, or procedures to ensure the appropriate compounding. So an example of this would be like transdermal patches or extended release products. You're going to need some pretty high-tech, pretty special training in order to make these. These aren't made in your traditional compounding pharmacies. Looking at the techniques used to compound, first, we have trituration, which is reducing a particle size by the use of a mortar and pestle, and you can see here an example of a mortar and pestle. Then we have levigation, which is the creation of a paste, usually by trituration while wet. So we'll add a little bit of water or a syrup to the powder in the mortar and pestle, and we'll triturate it until it forms a paste. Then you have spatulation, which is the mixing of solid materials by continuously heaping them together with a spatula until a homogeneous mixture is obtained. With a homogeneous mixture is just a mixture that is chemically identical throughout. So water versus Italian dressing. So you want to make sure that there's no separation of anything within your mixture. The same way that Italian dressing, the oil can separate out. That would not be homogeneous, but when you shake it, then it does become homogeneous. So with spatulation, you'll typically have an ointment and some powder, and you'll continue to heap the powder into the ointment until it's all uniform. This is very similar to making dough or making a bread or anything like that, where you continue to heap the ingredients such as flour and sugar into the dough until the dough is completely uniform versus having little clumps of flour or little clumps of sugar. You make sure the whole thing is the same. Similar to sterile compounding, non-sterile compounds have beyond use dates assigned to them as well. They're determined by USP 795 standards unless other stability and storage information is provided. So you have water-containing oral formulations, which are good for 14 days at controlled cold temperature. Then you have water-containing topical and mucosal liquids and semisolids. Those are going to be good for 30 days. And then finally, non-water-containing formulations are going to be good for 6 months. Now we have hazardous compounding. So these standards are set forth by USP 800. So we talk about USP a little bit more throughout this course, but USP 797, is targeting sterile compounding. USP 795 is targeting non-sterile compounding like we just talked about, and USP 800 is targeting hazardous compounding. So both non-sterile and sterile hazardous drugs must be compounded separately from non-hazardous drugs. They must be compounded in a separate room, and the room must be negative pressure. When the door to the room opens, air is drawn in, like we talked about, and you must have at least 12 air changes every hour. So the air has to cycle through at least 12 times per hour. You must have your own equipment, devices, and means for cleaning for hazardous drugs. You can't use the same equipment for your non-hazardous drugs. The hazardous drugs must be stored separately from non-hazardous drugs, and PPE must be donned at all times while manipulating hazardous drugs. This leads us to our final topic of this lecture, which is medication repackaging. In institutional pharmacies such as hospitals and some long-term care facilities, medications must be unit dose to give to a specific patient. So all unit dose means is that there's only one dose of medication in every unit. So these are pretty common. You see them with your cough and cold products over the counter. It's where you have to pop the pill out of the pack. There's only one pill in the actual slot where the pack opens. So some medications can be bought in unit dose material, like those medications I was just talking about, but some have to be repackaged into that material. Unit dose machines take bulk bottles of medications and dispenses them in individual doses. So in this situation, you would buy a 500 count of whatever medication you need, you pour it into the machine, and then it'll package it into unit doses for you. So here's an example of unit dosing. You can see the machine on the left, which is what you actually put the pills into, and then it'll add it to the foil. On the right, here's an example of a unit dose label for Tylenol. This is where it's been repackaged into a nice little package with only one caplet in it. When looking at the legal requirements for repackaging, the packaging requirements include that it must be properly labeled, it must protect from the environment, so heat, moisture, light, air, etc. It must protect the medication from breaking, and they typically expire 1 year from repackaging unless the manufacturer's expiration date is sooner. So anytime you take something out of the package and put it in a new package, it gets a new expiration date of 1 year unless for some reason the manufacturer's expiration date was shorter than 1 year. The labeling requirements include each dose must be labeled with the medication name, dose, NDC, lot number, and expiration date. Unlike compounding, these medications are not patient-specific. You need to refer to your state's laws and regulations as well as your pharmacy's SOPs for the expiration date and log requirements for these medications. Some companies may use shorter expiration dates than 1 year for safety. Some require that you need to log all of your unit doses. They're going to have different amounts of information you need to log for them. So just make sure that you're up to date on the procedure for how to do this when you start at your pharmacy. So with all of that being said, compounding may be used to provide a patient with a custom prescription that's not commercially available. Reconstituting consists of adding a base to a medication that is commercially made. Repackaging, on the other hand, allows for medications that are made in bulk to be dispensed in unit dose packaging. Factors such as sterility and whether a medication is hazardous help to determine both the facility needed as well as the compound requirements such as the PPE and the beyond use dating. Common techniques such as reading the meniscus and the aseptic technique can be used to ensure the prescription is accurate, effective, and safe. So before we go, we are going to compare compounding versus reconstitution just to solidify it. So a compound requires a maintenance of a master formulation record, compounding record, SOPs, and ingredient record. They follow USP standards for dating and storage guidance and are made of one or more ingredient that's not commercially available. Whereas a reconstitutable follows the manufacturer's recommendations for mixing, they are commercially available. They do not need to be documented in a log, and they follow the manufacturer's dating and storage guidance. Both of them may involve the use of an equipment like a graduated cylinder for liquid measurement, and they may require special storage such as being in the refrigerator, and likely they are all also dispensed for individual patients. Now we're also going to compare and contrast non-sterile versus sterile compounding. So non-sterile uses the skin and GI tract to protect against microorganisms like bacteria and viruses. It follows USP 795 standards. It does not need special airflow, and it typically deals with topical, oral, rectal, vaginal, nasal, and otic dosage forms. On the contrary, sterile bypasses the body's natural defense mechanism because it's being injected straight into the blood a lot of times, or being put in the eye, or something that doesn't allow for the body to screen for all of those microorganisms. It typically deals with inhaled or parenteral dosage forms, so also the lungs. Follows USP 797 standards and must be compounded in a sterile location. Both of them may involve the use of equipment like syringes and adapters for measurement. They both may require special storage, again, like refrigeration. They both should be dispensed for individual patients, and they both require documentation. With that being said, that's the end of this lecture. I hope you found it interesting. It's a side of pharmacy that a lot of people don't know about or don't know that it's an option. So definitely look into it if you're interested, and feel free to reach out if you have any questions. Thanks.